Okay, let's just jump right into this explainer because the highly anticipated 2026 ACC/AHA Dyslipidemia Guidelines are finally here. And honestly, they represent a massive, paradigm-shifting update for modern cardiology. We're looking at a fundamental rethinking of how we protect our patients from cardiovascular events. We're moving completely away from those older models and embracing a much more proactive, precise, and frankly, aggressive approach to lipid management.
So right off the bat, we have to ask a pretty crucial question. Is your current clinical practice falling behind? Are your cholesterol targets out of date? The 2018 guidelines were a great stepping stone for sure, but medicine has evolved. If you're still relying solely on those older frameworks, you might literally be missing critical opportunities to intervene before atherosclerotic cardiovascular disease, or ASCVD, truly takes hold in your patients.
And that brings us to our very first absolute top take-home message from the new guidelines. Treat earlier, aim lower, reduce lifelong ASCVD risk. We've got to intervene earlier, even starting health behavior counseling in youth. Why? Because this proactively reduces lifelong exposure to atherogenic lipoproteins. It's all about understanding that cholesterol burden is cumulative. Think about it like smoking pack years, right? We need to start thinking in terms of cholesterol years. By treating earlier and aiming lower, we're directly attacking that long-term, lifelong risk.
So today, we're focusing on the critical updates from the top 10 takeaways. We'll be looking at assessing risk with the CPR model, the return of hard goals, taking a deep dive into advanced testing, imaging, and reclassifying risk, and finally, treating high-risk groups.
Starting with Section 1, Assessing Risk, the CPR model.
Now, this is where we see a real paradigm shift. The old pooled cohort equations, the PCE we've all been using, those are officially out. And the far more contemporary PREVENT equations for 10 and 30-year risk assessment, those are in. These new PREVENT equations allow us to categorize patients into low, borderline, intermediate, or high risk with so much more precision. They use a broader, much more relevant set of variables to estimate those critical 10 and 30-year horizons.
To actually use this new standard in the clinic, the guidelines introduce a really brilliant, memorable mnemonic. It's called the CPR model. Step 1, calculate. Step 2, personalize. Step 3, reclassify. Basically, first you calculate the 10-year ASCVD risk using the new PREVENT equations. Next, you personalize that estimated risk to your specific patient by factoring in risk-enhancing factors that aren't captured in the base equation. And finally, you reclassify with the selective use of coronary artery calcium scoring, which lets you reassess and really lock in those treatment recommendations.
Moving on to Section 2, the return of hard goals.
Honestly, this is a major victory for clarity in patient care. Hard, absolute targets are back. This makes it so much easier to guide lipid-lowering therapy across primary prevention, severe hypercholesterolemia, and clinical ASCVD. While achieving a percentage reduction in LDL-C is obviously still a priority, we now have strict, absolute numbers to hit for LDL-C, non-HDL-C, and even ApoB across various patient populations. It really just takes the guesswork right out of treatment intensification.
And the absolutely crucial point here is how aggressively we're now treating very high-risk secondary prevention patients. Get this, we are now targeting an LDL-C goal of strictly less than 55 milligrams per deciliter and a non-HDL-C goal of less than 85. Less than 55. To reach these super aggressive levels in patients already on maximally tolerated statin therapy, the guidelines make it totally clear that it's highly reasonable to add ezetimibe, a PCSK9 inhibitor, or bempedoic acid. We are pushing lower than ever before to protect these vulnerable patients from recurrent events.
Next up, Section 3, Deep Dive, Advanced Testing.
Because setting goals is just one piece of the puzzle, right? We need to talk about apolipoprotein B, or ApoB. Why does this matter to your patient? Well, ApoB testing is now a top recommendation to guide therapy for folks with elevated triglycerides, diabetes, or even those with an already low achieved LDL-C. See, once standard LDL-C and non-HDL-C goals are met, measuring ApoB is incredibly useful because it helps identify adults with residual elevated lipoprotein-related risk. It literally counts the actual number of atherogenic particles, giving you the real picture when a standard panel might falsely reassure you.
Similarly, we have to talk about lipoprotein A, or LPA. The new guidelines explicitly mandate that LPA should be measured at least once in a patient's lifetime. Why? Because elevated levels are a glaring indication for more intensified LDL-C lowering. The risk scales dramatically here. If LPA is at or above 125 nanomoles per liter, the risk increases 1.4-fold. But if it hits 250 nanomoles per liter, the estimated risk actually doubles. It's a massive risk enhancer, and knowing this number is absolutely essential for optimizing early control of other modifiable risk factors.
Which brings us to Section 4, Imaging and Reclassifying Risk.
Another critical takeaway emphasizes that coronary artery calcium, or CAC scoring, is a vital tool for reclassifying risk in those tricky borderline and intermediate patients. It helps us determine exactly who needs statin therapy. We're utilizing this in men aged 40 and older and women 45 and older. What's crucial to understand here is that both the absolute amount of calcium and the corresponding standardized percentile based on age, sex, and race have real prognostic importance. Essentially, it takes the patient off the fence and gives you a definitive path forward.
Finally, Section 5, Treating High-Risk Groups.
This comprehensive flowchart really pulls it all together. It shows exactly how to use those prevent equations to initiate statin therapies for patients falling into borderline and intermediate risk categories. Let's trace the path together. After health behavior counseling and calculating risk, if your patient falls into the intermediate 5 to 10% risk bucket, the standard is to start a moderate to high-intensity statin. But if the decision is a bit uncertain, you follow the chart down to the CAC assessment. If the CAC score is greater than 0, you initiate statin therapy. It beautifully systemizes the whole shared decision-making process.
And listen, we absolutely cannot overlook this part. For primary prevention in patients with diabetes, stage 3 or 4 chronic kidney disease, or HIV, immediate LDL-lowering therapy is strongly recommended, regardless of their baseline LDL-C level. For adults aged 40 to 75 with these specific conditions, their baseline risk is already so inherently elevated by the disease state itself that we just bypass the standard wait-and-see approach. We initiate therapy right away to aggressively protect their cardiovascular system.
So, as we wrap up this explainer on these truly transformative 2026 guidelines, I want to leave you with a question to chew on. With absolute goals back and the prevent tools at your disposal, how will you reclassify your patient's risk tomorrow? How will you use this new playbook to start treating earlier and aiming lower? From the CPR risk assessment model to strict absolute targets like 55 milligrams per deciliter for secondary prevention, we have the tools. Now it's time to update our practices, utilize ApoB and LPA testing, and proactively reduce that lifelong burden of ASCVD. Thanks so much for joining me on this deep dive.